If headaches are severe or frequent, then prophylactic medication may be warranted. Beta blockers, tricyclic antidepressants, verapamil can be helpful. Beta blockers are contraindicated when there is a question of asthma or idiopathic hypertrophic subaortic stenosis, and should only be considered with caution of if there is a history of possible depression. Tricyclics can cause a morning hangover, and the latter, that is the tricyclics, more than the former. So the latter, that is the tricyclics, cause a morning hangover. Cyproheptadine and monoamine oxidase inhibitor antidepressants provide less predictable migraine prophylaxis. Newer anticonvulsants such as gabapentin and topiramate may reduce the intensity of the pain. If these fail, then prophylaxis with a methyl salicylate, a serotonin blocker, can be considered after every 3 months of treatment. It must be stopped for 4 weeks to reduce the risk of retroperitoneal fibrosis or other serious connective tissue dysfunction. Methisargide is contraindicated in patients with ischemic heart disease, severe hypertension, peripheral vascular disease, phlebitis, peptic ulcer, hepatic and or renal failure, valvular heart disease or collagen disease. Taking high estrogen oral contraceptive pills exacerbates the migraine. Low dose estrogen oral contraceptives may not increase the intensity of the frequency of the migraines. Use of estrogen for contraception may increase the risk of brain infarction. In 60% of premenopausal women, migraines recur or intensify during the days before menstruation. This corresponds with the nadir of plasma estradiol and progesterone. Nadir means the lowest levels. Progesterone supplementation did not delay the onset of migraines in women with menstrual migraines, but estradiol supplementation did in many women with catamental migraines. Prophylaxis: taking high estrogen oral contraceptive pills exacerbates the migraines. Low-dose estrogen oral contraceptives may not increase the intensity or frequency of migraines. Use of estrogen for contraception may increase the risk of brain infarction. In 60% of premenopausal women migraines recur or intensify during the days before menstruation. This corresponds with the nadir of plasma estradiol and progesterone. Progesterone supplementation did not delay the onset of migraines in women with menstrual migraines, but estradiol supplementation did. In many women with catamental migraines, prophylaxis can be achieved by preventing the drop in the estrogen that occur before menstruation. Application of an estrogen patch 2 days before the onset of the menstruation prevented the migraines in 18 of 26 women compared with one of the 7 placebo-treated controls. Daily treatment with 2.5 mg of bromocriptine reduced the migraine frequency in 75% of the women. Most women migraines have relief from the migraines during pregnancy, and this is independent of the sex of the fetus. Women with a history of catamental migraines are substantially more likely to go through pregnancy without migraines compared with the women whose migraines are not coupled to their menstrual cycles. Now we come to the end of my lecture series, and the next part of this lecture series will be taken up later on. Thank you.